So now we'll study the bone pathology, diseases of bone. First we'll study the bone disorders are divided into a lot of variety of groups based on the etiology, like infectious diseases of bone, neoplastic diseases of bone, non-neoplastic diseases of bone, developmental diseases of bone. So first we'll study the developmental diseases and non-neoplastic diseases of the bone. These are actually non-infectious in nature. So first are the developmental disturbances or the developmental disorders of bone. They may be present at birth, they may be seen at the time of birth in infants, or maybe congenital disorders. Bone disorders are like a variety of symptoms, like they may be congenital disorders associated with few syndromes, or they may be seen like isolated ones. So we are going to study in today's topic osteogenesis imperfecta, osteopetrosis, cleidocranial dysplasia and cherubism. Cleidocranial dysplasia is a skeletal dysplasia actually. Okay, first is the osteogenesis imperfecta. What is osteogenesis imperfecta? Osteogenesis imperfecta, it's considered a serious disease. Okay, it is hereditary in nature, transmitted as autosomal dominant form with a variety of mutations. Most commonly it is autosomal dominant only. It's known by other names like brittle bone or Lobstein's disease. So what gives rise to osteogenesis imperfecta? It is basically arising from abnormality in type 1 collagen molecule. So there is some defect in formation of collagen molecule, type 1 collagen. Type 1 collagen, it's normally seen in bones or organ capsules, fascia, sclera. So these are the places where type 1 collagen is seen. So here in this condition there is a defect in formation of type 1 collagen. So all these areas where we normally find type 1 collagen are affected. And there is both qualitative and quantitative defect. Even if the type 1 collagen is formed, there is like failure of bone matrix and proper maturation of the collagen. The collagen form may be very immature. So thus it leads to extreme porosity of the bones, weakness of the bones, thereby leading to fractures. So basically 4 types of osteogenesis imperfecta are present. There is a type 1, type 2, type 3 and type 4. Type 1 and type 4 are like seen in infants at the time of birth, whereas type 2 is seen even in utero cases, and the type 2 is specifically seen in utero. Type 3 is seen both in utero and neonatal period. The clinical features of osteogenesis imperfecta, basically it is the fragility of the bones. The bones are very fragile, extremely porous, thereby leading to fractures. So pathologic fractures are more common here. And the other characteristic of osteogenesis imperfecta is the presence of pale blue sclera. What happens, type 1 collagen is present in sclera, right? Here there is abnormality in type 1 collagen. So the sclera are extremely thin and there is abnormality in type 1 collagen. Both this leads to the pigmented choroid being shown through the iris, thereby giving the appearance of a blue sclera. And the other association of osteogenesis imperfecta is with the malformation of teeth, that is the dentinogenesis imperfecta. Basically what happens is osteogenesis imperfecta or dentinogenesis imperfecta both give rise to a defect in the mesodermal tissues. So that's that accounts for the dentinogenesis imperfecta. You'll see the bones are weak, the ligaments are fragile. So now we'll study the all the types in detail. So type 1 osteogenesis imperfecta, it's basically seen in infants, right, present at the time of birth. Here the bone fragility or the weakness of bones is like mild to moderate. It's associated with fractures. Presence of pale blue sclera is present. Again, this type 1 osteogenesis imperfecta is divided into 2 types, like subtype A and subtype B. So subtype A, it is not associated with dentinogenesis imperfecta. Subtype B, it is associated with dentinogenesis imperfecta. And because of the extreme weakness of bones, even the spine is bent. So that condition is called as the kyphoscoliosis. the spine will be bent on one side and the shoulder will be raised to that side. So these individuals have, throughout their life, they have to suffer because of the bent spine. And they have short stature. Because the bones are weak, they are not able to bear the weight of the individual. Thus, the individuals have a short stature, or the bones become bowed down. Basically, this bowing is seen because of repeated or multiple fractures of the area, not actually the length of the bone is reduced. The length of bone is normal, but because of repeated fractures and healing of that area, it leads to shortened bone appearance. So sometimes this osteogenesis imperfecta, it also affects the otosclerosis. It leads to a condition called otosclerosis. Hence, there will be hearing loss. Hearing loss in type 1, it develops before the ages of 30 years. And yeah, type 1 osteogenesis imperfecta is an autosomal dominant inherited one. Next is the type 2 osteogenesis imperfecta. The type 2 osteogenesis imperfecta, here there is extreme bone fragility and severe fractures are seen. When compared to type 1, type 2 has severe fractures. And this type 2 is seen in utero, means before even the birth of the individual, the patient would have, the infant would have suffered multiple fractures in the womb itself. So these infants are like stillbirth individuals. They may not be alive at the after delivery. So even if they are alive, there will be severe fractures. Like even just if you touch the infant or baby, there are chances of the baby developing fractures. Blue sclerae will be present. Dentinogenesis imperfecta will be present. Most of the times, the child affected with type 2 osteogenesis imperfecta will die within the first year of life because of repeated infections, repeated fractures. So yeah, micrognathia is present and the individual has a short trunk. These are diagnosed, these cases of type 2 osteogenesis imperfecta are diagnosed by ultrasound or USG, and even in clinical features we can see that for 90% of the times the infant or the baby is stillbirth, that is, he may not be alive. Then the type 3 osteogenesis imperfecta, here there is severe bone fragility, and yeah, blue sclerae are present in all the cases, but type 3 shows a characteristic feature that blue sclerae are present in infants and they usually fade as the child develops, or as the child enters adulthood, the blue sclerae fades away. And mortality rate is higher here because of the fractures, the infections, and the characteristic feature is the facial appearance of a triangular face with a frontal bossing. And the limbs are shortened. The limbs are not actually short in length, because of the fractures only they appear to be short in length. Type 4 osteogenesis imperfecta also has a similar feature of fractures, sclera, presence of blue sclera, and the fractures are that the characteristic feature is that the frequency of fractures, it decreases after puberty. So during growing years, before the presence of the growth spurt, the child shows a lot of fractures. So after growth spurt, at the time the puberty starts, the fractures literally stop, or the incidence decreases. Yeah, dentinogenesis imperfecta, because it is a disturbance in mesodermal tissue, we can see all the characteristic features of dentinogenesis imperfecta, that is the blue-gray opaque color of the crown. Then the pulp chamber shows obliteration. So all the features of dentinogenesis imperfecta, both type 1 and type 2, may be seen here. So yeah, so oral manifestations are nothing but the affected teeth show blue to brown translucency. So the radiograph shows premature obliteration of the pulp, and there will be micrognathia, right? The maxilla will be maxillary hypoplasia is seen. So the teeth gives an appearance of a class 3 malocclusion, but there is no mandibular hyperplasia as such. Only the maxillary micrognathia is present. So because of the presence of class 3 malocclusions, we know that we can see lot of cross bites, anterior cross bites, posterior cross bite, or sometimes open bites may also be seen. And presence of impacted or erupted teeth because of failure of eruption or failure of shedding of deciduous teeth or failure of eruption of permanent teeth. So here you can see in the radiologic picture that though the bones are formed normally, they appear to be of shortened or bowed bones, and there is increased radiolucency in bones when compared to the normal bones. Yeah, the limbs are shortened. So radiographically we can see osteopenia, bowing of bones, and the deformity. It affects the long bones especially, and yeah, it affects the spine too, because in type 1 osteogenesis imperfecta we see that the whole of spine is bent, that the condition kyphoscoliosis is seen. So multiple fractures, same site may be repeatedly fractured, and presence of Wormian bones in the skull, that accounts for the frontal bossing in case of type 2 osteogenesis imperfecta, and triangular faces in case of type 3 osteogenesis imperfecta. So these are the radiologic features. So when we observe the picture microscopically, you can see that the cortex is extremely thin. Then whatever the cancellous bone is formed, it is very delicate and it shows microfractures because of presence of immature spongy bone in the cortex. The osteoclasts are present. They may synthesize few of they may show deposition of osteoid, but whatever the quality is formed, it's of reduced variety. So the bone matrix synthesis is reduced. The collagen which helps in synthesis of osteoid, it's also absent or defective, and there is defective microvascular system. So all these account for the histologic features of the osteogenesis imperfecta. There are no specific known treatments for osteogenesis imperfecta, apart from the fact that whenever you see a fracture, you go for the reduction of fracture and immobilization. So symptomatic treatments have to be given. And suppose there are infections occurring in the bone, like presence of osteomyelitis and all, you have to treat the condition accordingly. Apart from that, the most serious of all the types of osteogenesis imperfecta is the type 2 osteogenesis imperfecta, because it affects in utero, and all the childs, almost all, they are stillborn. That is, they may not live, even if they are born, they may not live beyond the first year after birth. Other types are relatively milder ones, and they show recurrence of fractures and all. So no specific known therapy is present to treat osteogenesis imperfecta as such. So when you notice dentinogenesis imperfecta, you have to treat the cases accordingly, so for cosmetic reasons. So the next hereditary bone disorder is the osteopetrosis. It's also known by other names as marble bone disease and Albert-Schönberg disease. Here basically there is an increase in bone mass. Osteopetrosis has to be differentiated from other commonly known disease, that is the osteoporosis. Both show fragility of bones. Bones are fragile, but osteopetrosis shows increased bone mass, whereas osteoporosis shows decreased bone mass. Okay, so we are going to study osteopetrosis first. So it is due to defect in bone remodeling. Here what happens is the increase in bone mass, there is the failure of osteoclastic resorption of bone occurs. So whenever to keep a system in balance, both procedures are occurring. That is the deposition of bone and the resorption of bone simultaneously as need arises. But whenever there is continuous deposition of bone without resorption, that is the osteoclasts fail to resorb bone, so that results in thickened mass of bone, that is the osteoporotic bone, osteopetrosis condition. So here basically the defect is in osteoclasts. So clinically we can see three types of osteopetrosis. There is the infantile form, intermediate form, and the adult form. So we'll study each of them. The infantile form is more malignant. It is also known as malignant osteopetrosis. It is like more severe form of the disease. It is transmitted as autosomal recessive trait, diffusely sclerotic skeleton, What happens is, because of increased bone deposition, you can see lot of bone deposition in whole of the body, whole of the skeleton, and the foramina, the cranial nerve foramina, whatever are there, they have to expand to accommodate all the nerves. So here there is failure of resorption. So what happens is the foramina don't widen, and the cranial nerve compression is seen, leading to variety of symptoms like proptosis, hydrocephalus. All signs of cerebral nerve function dysfunction may be seen. So yeah, and what happens is this increased bone mass, it also replaces the medullary bone marrow. So then you can see features of anemia, normocytic normochromic anemia, hepatosplenomegaly, and increased susceptibility to infections is seen. So that is about the infantile osteopetrosis. So it shows signs of cranial nerve compression because the foramina don't widen properly, and because the bone marrow is being replaced by the osteoid tissue. Then you can see symptoms of pancytopenia, anemia, osteomyelitic infections are seen. So this infantile is more severe form. Then the intermediate osteopetrosis. Here the affected patients usually show defects in the limbs. They may have short appearance. They may be asymptomatic at birth. Both the infantile and the intermediate osteopetrosis, they are not detected until about 10 to 15 years of age, until the child reaches adolescence. In infants, it's not detected. It's because all the cases are asymptomatic. They are detected only at about 20 years of age, like in adolescence. Here also you can see cranial nerve defects, macrocephaly, and anemia, presence of anemia, and ankylosed teeth or impacted teeth may be seen. Impacted teeth and ankylosed teeth. So adult osteopetrosis is transmitted as autosomal dominant form, seen in later stages of life, because during early stages or in infancy, the child remains asymptomatic. So axial skeleton shows sclerosis, and the initial manifestation of the disease is the bone pain. Bone pain which is just dull in origin, which is transmitted to the soft tissue. It is a dull aching pain. So and there is increased susceptibility to infections. So about 10% of cases show osteomyelitis of mandible also. So here in this radiograph, actually this is the radiograph of pelvis region. So you can see there is radio opaque regions are seen, so showing the increased bone mass. Normally what is the pelvic region is there, so the borders should be more radio opaque than the inside, but here you can see that extreme radio opaque regions are seen. So when you see microscopically there are presence of both the osteoblast and the osteoclast, but the osteoclast they fail to resorb the skeletal tissue. So there are remnants of mineralized primary spongiosa, that is the immature spongy bone is seen, and there is amorphous bone deposition in various places. There is increased presence of osteoblasts are seen. Osteoblasts, they may show presence of multiple nuclei, so showing increased bone deposition or increased osteoid formation. There is osteophytic bone formation is seen. So when you see a radiographic picture, as we have seen the radiographic picture of pelvis, there is increased bone mass, there is increased bone density seen, and distinction between the cortical and cancellous bone is lost. There is more, both the periphery and the whole of the surface of bone appears to be uniform. And when we see oral cavity, the teeth, the roots show extreme hypercementosis. So you cannot distinguish between the alveolar bone and the root. There is the roots appear to be blended with the bone. So such radio opaqueness of the bone is seen. The alveolar bone shows such radiopaqueness that you cannot distinguish between the both, that is, and even the roots are hypercementosed here. So then we see the radiographic features of osteopetrosis. We see the characteristic endosteal proliferation of bones, that is nothing but the end on bone appearance. Then when we see only the vertebrae of the individuals, we can see increased bone deposition. So that is given the term Rugger-Jersey sign. Okay, these two are characteristic features, and histologically also, as we have seen that there is increased presence of osteoid or osteoid deposition, and osteophytic bone formation is seen. So now we are going to see another skeletal dysplasia, that is the cleidocranial dysplasia. It is also a developmental disorder, congenital in origin. It is basically inherited as an autosomal dominant trait. Cleidocranial dysplasia. Basically, in this disorder, there is absence of one or more clavicles. There is clavicular hypoplasia. The clavicle may be reduced to just a few fragments, or it may be completely absent. So what happens whenever the clavicle is absent, the patient, the infant can get his shoulders and approximate both the shoulders in front of the chest. So the extreme condition, normally we are not able to get our both the shoulders to the front, right? So in this cleidocranial dysplasia, because of the absence of clavicle, there is extreme movement of the shoulder girdles, and the individual can approximate both his shoulders. So this disorder, basically congenital hereditary disorder, seen in infants or children. Most commonly affected bones are the skull bones, clavicles and the jawbone. This disorder, it affects the skull, jaw, teeth. Like what happens in the skull? Skull, normally the sutures, whatever are present, they are supposed to close by the time the individual develops. So during development, the sutures should close. But in cleidocranial dysplasia, even when you observe the X-ray of an adult patient, you can see the sutures are open. The fontanelles didn't close. So open sutures is a characteristic feature. Then the clavicles may be absent, or even if present, only fragment may be seen. Both, one or both, it may be symmetric bilaterally. So because of the extreme characteristic absence of clavicle, you can see the other features like when it affecting the skull, the sutures remain open, and the sagittal suture, which is sunken, so it gives the appearance of a flat skull. Then the paranasal sinuses are underdeveloped, and the individual has short height, and the skull is underdeveloped. Because of failure of sutures to close, the frontal bursting, that is the extreme appearance of the frontal bone is seen. Then the nose is broad with depressed nasal bridge. So shoulders show the defect because they droop excessively because of the absence of clavicle, and unusual mobility is seen. So basically the paranasal sinuses are underdeveloped, and the shoulders show extreme mobility. So when you see the oral cavity, the maxillary hypognathia may be seen, that is the maxillary hypoplasia may be seen. Then the presence of cleft palate has been accounted more in cleidocranial dysplasia cases, and the palate, whenever it is present, the palate may be of a high arched type, that is situated high because of the absence of the development of maxilla. There is underdevelopment of maxilla. The palate is like high arched palate. And when you see the teeth, multiple impacted supernumerary teeth may be seen, and the deciduous teeth show relative failure to shed off. So permanent teeth may be unerupted. There is prolonged retention of deciduous teeth, and there is failure of eruption of permanent teeth also. And the roots of the teeth are usually very short and thinner than usual. So here you can see a radiographic picture which is showing multiple impacted or supernumerary teeth. There are a variety of syndromes exhibiting this condition. there is multiple impactor and supernumerary teeth, but when you compare it with the external skeletal features like the absence of clavicle and all, you can just say that this is a cleidocranial dysplasia syndrome. This is a condition of cleidocranial dysplasia. So here you can see in the radiographic feature of skull, this is of middle-aged individuals around about 20 years of age, around about 12 to 20 years of age. Here you can see the sutures have not closed yet. Actually they have to close, but they didn't close, the presence of open sutures and the frontal bossing appearance of the skull. So radiographical characteristic features are the open skull sutures, Wormian bones, absence of clavicle, and the underdeveloped maxilla. There is no specific treatment for this condition other than whenever it's affecting whole of oral cavity with so many impactions and so many retentions of deciduous teeth, you have to make an attempt to restore the jaws to normalcy, that is to restore the development of maxilla. If cleft palate is present, you have to correct by correcting it surgically. So that's about cleidocranial dysplasia. Previously it was thought that cleidocranial dysplasia affects only the clavicle, but now it has been showed that cleidocranial affects whole of the skeleton with its effects on the skull, jaws, and even the clavicle. So now we are studying the other commonest developmental disorder, that is the cherubism. Cherubism, basically it affects the children. It affects the children, or it is not seen until 1 to 3 years. It begins at 3 years and it goes on progressing up to 5 years of age. After that, when the child attains the puberty, this disease automatically stops and regresses itself. So cherubism, it's also known as familial multilocular cystic disease of jaw. Basically this disease, it's transmitted as an autosomal dominant trait. So pathogenesis is the mutation of genes which have been mapped to this chromosome number 4. So this mutation, it leads to activation of osteoclasts and disruption of jaw morphogenesis. Basically this cherubism, it affects the jaws of infants. So they show bilateral and symmetric enlargement of jaws, giving the patient the full-faced appearance. Along with the enlargement of jaws, there is associated lymphadenopathy. So that gives rise to this full-faced appearance. So clinical features that affects children from about 3 years to 5 years. Though the individuals are normal at birth, they show beginning of symptoms around 3 years of age up till 5 years. Then after that, it shows regression. The disease may stop or it just be there like that, and when the child attains puberty, the disease automatically regresses. Associated lymphadenopathy is also seen here. Bilateral involvement is seen, bilateral involvement of jaws is seen. So the lesion shows painless expansion of jaws. So the characteristic feature of this cherubism is the sclera. Beneath the sclera, a rim of sclera may be seen beneath the iris. Beneath the iris you can see a rim of sclera that gives the appearance of eyes turned to heaven appearance. So whatever the child is you are seeing, he shows full appearance, that is he shows the characteristic chubby cheek appearance. So the maxilla may be enlarged aggressively, it shows excessive enlargement. Then there will be displacement of teeth, because whenever there is such a huge expansion of jaws, it automatically disturbs the underlying teeth. So the teeth may be displaced, or there is failure of eruption of permanent teeth, failure of shedding of deciduous teeth. Sometimes because of the expansion, even root resorption of teeth present in the maxilla may be seen. And there is painless and progressive expansion of the jaw. So the position of teeth may be altered. There is the transposition of teeth or rotation of teeth. So when you see a radiological picture of maxilla, you can see the expansile nature of this lesion. So radiographically, the cherubic look, that is a full fade or the chubby cheek appearance, it presents as expansile multilocular radiolucency, and the whole of bone, it appears radiolucent because the lesion is essentially a fibrous one. Whatever the lesion is expanding, it is not because of deposition of osteoblasts, it is because of the fibrous nature of the lesion. That is, fibroblasts are contributing to this expansion of lesion. So radiographically you can see a lucent lesion with the presence of teeth. Whole of the alveolar bone appears lucent, and the presence of so many teeth in a lucent bone, it gives the appearance of a floating tooth syndrome. Because numerous unerupted teeth are present, deciduous teeth are unerupted, deciduous teeth are not exfoliated, permanent teeth are unerupted, all these are present in a radiolucent bone. So it gives an appearance that the teeth are floating in a bone. Floating tooth syndrome. Cherubism, it has also been associated with another syndrome like the called the Noonan's syndrome. So Noonan's syndrome is nothing but presence of cherubic look along with other symptoms of the Noonan syndrome. So the histologic appearance is similar to that of a fibrous dysplasia, that is the non-specific ground glass appearance. It has also been stated that cherubism is a form of fibrous dysplasia. So here in the radiological picture, OPG, you can see the maxilla. It's like more of radiolucent in appearing to be of larger in size when compared to the mandible. So radiographically, we have seen that cherubic patients show floating tooth syndrome because there is the destruction of bone and presence of numerous unerupted teeth. Yeah, because of the fibrous nature of the lesion or this cherubic patients present the ground glass appearance similar to seen in fibrous dysplasia. So when you see microscopically, there are presence of multinucleated gain cells which are which show nothing but there is deposition of osteoid formation, and the capillaries, they show large endothelial cells and there is presence of perivascular cuffing. So this deposition of bone along with increased destruction here. So treatment for cherubism is nothing but cosmetic surgery which is done after puberty, because after puberty normally the condition regresses. So you have to wait until puberty. So if the lesion doesn't regress on its own, then you have to carry out the cosmetic surgery. So other commonest disease of bone, non-neoplastic disease of bone, is the Paget's disease of bone. This is not a developmental disease. Paget's disease of bone has been placed under diseases of questionable etiology because it is neither developmental, non-neoplastic, nor infectious in nature. So the etiology of Paget's disease, it has been attributed to viral infections or inflammatory causes. Specifically, few of them have associated it with measles infection, or it is of unknown etiology, basically autoimmune in nature. This Paget's disease affects the middle-aged and elderly individuals, also known as osteitis deformans. This condition is characterized by abnormal and excessive remodeling of bone. That is, bone is resorbed and deposited, but in an abnormal fashion. So even whatever after resorption by osteoclasts, whatever bone is deposited, it is of immature variety. So coming to the clinical features of Paget's disease, so it is specifically seen in middle-aged and elderly individuals only, and male to female ratio is 1:1, that is equal predilection, and more commonly the bones of skull, axial skeleton, lumbar vertebrae, pelvis, femur, tibia. It affects overall all of the major bones, proximal bones, and skull more commonly. So initially the disease is asymptomatic, or there are presence of dull aching pain, pain involving the soft tissue like that. It is a very dull aching pain. So, and there is limited movements of the joints. Whatever joints are involved, suppose the femur and tibia or whatever are involved, they show limited movement or weakening of the joints. Patient may complain of a weakening of the joints or limited movement along with a dull aching pain present. So Page's disease is a remodeling of bone. Remodeling involves both the deposition as well as the resorption. So there is osteoclastic resorption of bone, which is being replaced by deposition by osteoblast, but it is of immature variety. So this leads the bone becomes enlarged, but it is very weak or not vascularized. So whatever weight bearing joints are present, the joints which bear the weight, the knee joint and all, they show bowing of bones. They become very weak. So whenever the skull is involved, patient may say that his skull is increasing in size. How he knows? He knows by the size of his hat. So he has to completely replace his hat after very few weeks. So he may give a history of replacing his hat size or feeling of fullness of skull or tightness of skull. So this is because the skull size increases progressively as and as the bone is deposited. So as and as the osteoblast deposit bone, so the skull size goes on increasing. And when coming to the oral cavity, there is enlargement of maxilla. So the maxilla becomes V-shaped. The term Leontiasis ossea has also been used specifically for the enlargement of facial skeleton or the maxilla. Leontiasis ossea, actually it is a term applied for fibrous dysplasia because the patient shows such a progressive enlargement of face that he gives a lion-like appearance. Here also the term Leontiasis ossea has been used, and the sinuses whatever are present, they are obliterated and nasal obstruction is seen. So when you see a radiographic picture of the bone affected, the Page's disease affects all of the bones, right? Like the pelvis or the axial skeleton, skull, whatever bone, whatever radiographic picture you take, it shows three different phases. First is the initial is the lytic phase, next is the mixed, both the sclerotic and the lytic phase. Third phase is the osteoblastic phase, that is the deposition of bone phase. So early lytic state, it shows a radiolucency and there is a change in the trabecular pattern. Normally the trabeculae are closely arranged, like, so they become irregular now. So the late stages show the osteoblastic state, that is the deposition of bone occurs. So there is patchy distribution of the bone, giving rise to this cotton wool appearance. When you see a radiograph, few of the areas are radiopaque and few are radiolucent. The radiopaque areas, they show that the trabeculae are not arranged in a regular fashion. So that gives this appearance of a cotton wool appearance. So when you see extensively in relation to oral cavity, extensive hypercementosis is seen, multiple unerupted teeth may be seen. Again, the deciduous teeth fail to shed and permanent teeth fail to erupt. So characteristic feature is nothing but this extensive hypercementosis, and there is loss of lamina dura surrounding the teeth. And laboratory findings are very unique in case of Page's disease because they show normal levels of calcium and phosphorus, but serum alkaline phosphatase level is elevated. Normally serum alkaline phosphatase level should be around 30 to 40, but in case of Page's disease it's up to 250 Bodansky units. So such a elevated level it is. Normal is 30, and you can see 250 Bodansky units of this serum alkaline phosphatase. Increased urinary calcium and hydroxyproline levels. Hydroxyproline, it shows the deposition of this collagen actually. So increased hydroxyproline levels show that increased amount of collagen or increased amount of osteoid is being deposited to repair the resorption whatever has occurred. So when you see a microscopic picture of Page's disease of bone, so again you can see initially there is bone resorption. This is brought about by osteoclasts. The osteoclasts are such huge that each osteoclast may show hundreds of nuclei. Then a few areas may show presence of osteoblasts. Osteoblasts are shown with irregular trabeculae of bone form, immature bone. Then whatever the connective tissue is there, it shows presence of large spindle-shaped fibroblasts. So this pattern of resorption and deposition occurs continuously. So what happens is here and there few of bone fragments are left out. So triangular shaped bone fragments are left out. They give the appearance of this jigsaw puzzle. So that pattern is called as the jigsaw puzzle or the mosaic pattern of bone. One is the radiological appearance of cotton wool appearance. The second histologic appearance of jigsaw puzzle. So whatever new bone is laid down by the osteoblast, it is just non-mineralized one or poorly mineralized and disorderly arranged trabeculae. So these account for the extreme fragility or the porosity of bones. Yeah, the bones are like osteoporotic ones, very weak ones. So this histologic picture, it shows the deposition of osteoid. Whatever the pinkish eosinophilic areas you are seeing, so those are just the deposition of osteoid. So there is no known treatment for this disease, the Page's disease, but few therapies like the bisphosphonate therapy has been carried out, and the hormone replacement therapy has been carried out, and calcitrione has also been carried out. And whenever there is associated pain or infection, accordingly you have to correct by drugs like anti-inflammatory drugs, and care has to be taken because this disease specifically it occurs in elderly individuals, right? So more cases of fractures have been reported. So now we are going to study the fibro-osseous lesions. Okay, fibro-osseous lesions are a diverse group of non-neoplastic lesions which are characterized by replacement of normal bone by fibrous tissue. So we have seen disorders where the bone there was defect in bone deposition as well as resorption. Here there is complete replacement of bony tissue by the fibrous tissue. So the classification of fibrous lesions involve non-neoplastic lesions and the neoplastic lesions. Non-neoplastic lesions are nothing but the fibrous dysplasia and the cemento-osseous dysplasia. Cemento-osseous dysplasia is of three types: focal, periapical cemento-osseous dysplasia, and the florid cemento-osseous dysplasia. So neoplasms are nothing but the ossifying fibromas. So here in this slide, this class will study the non-neoplastic lesions only. The neoplastic lesions will study them along with the neoplasias of oral cavity, other tumors of oral cavity. So the first is the fibrous dysplasia. So fibrous dysplasia, it is a skeletal developmental anomaly of bone forming mesenchyme where there is a defect in osteoblastic differentiation and maturation. So here what happens is, in this condition, the normal medullary bone, it is replaced by fibrous tissue. So there is proliferation of fibroblasts, so they replace the normal osteoid tissue. So basically the defect in fibrous dysplasia is in the osteoblast, maturation of osteoblast. So fibrous dysplasia, it is caused due to a mutation in GNAS1 gene. GNAS1 gene, the mutation of this affects in three ways. First, there will be hyperfunction of the endocrine glands. Then there will be defect in melanocyte formation or deposition. There is an increased deposition of melanocytes is seen. So that accounts for the cafe lot spots seen here. So defect in endocrine system and defect in melanocyte deposition is seen. So there are three types of fibrous dysplasia. There is the monostotic fibrous dysplasia, polyostotic fibrous dysplasia, and the craniofacial form. So monostotic fibrous dysplasia is a form of fibrous dysplasia which involves just a single bone. Almost 80 to 85% of cases show the monostotic form of fibrous dysplasia. The polyostotic fibrous dysplasia is when it involves entire skeleton or it involves more than one bone. So polyostotic form is of two types, Japhet type and the McCune-Albright syndrome. So the Japhet type of polyostotic fibrous dysplasia is where the entire skeleton is involved and there are presence of cafe-light spot or the pigmented macules. Whereas the McCune-Albright syndrome, it shows presence of polyostotic fibrous dysplasia along with mucocutaneous lesions, mucocutaneous pigmentation, that is the cafe-light spots, and presence of endocrinopathies, various form of endocrinopathies like hyperthyroidism and all. And the craniofacial form, and the fourth variant of fibrous dysplasia is the cherubism. Many authors have said that cherubism, the developmental disorder, is also a form of fibrous dysplasia. So first we'll study the monostotic fibrous dysplasia. Monostotic fibrous dysplasia, it affects children or younger adults in the first or second decade of life. So it has an equal predilection for occurrence in both males and females. So it involves maxilla, all of the jaws, both the maxilla and mandible are involved. Whenever the maxilla is involved, it gives an appearance of leontiasis osseous. There is such a expansile enlargement of the lesion in the maxilla that it gives a leonine appearance of face. So that's the term leontiasis osseous is used. So initially, whenever it affects the maxilla, there is a bulge in the labial or buccal mucosa. Yeah, it may extend to the lingual plate also, but the buccal plate or the cortical plate, it shows expansion. So there is a painless swelling or bulging of the jaw. So whenever there is expansile nature of the lesion, or the lesion here is fibrous in nature, it's expanding. So it how does it affect the jaws? The teeth which are present in oral cavity may be displaced, or there may be failure of eruption of deciduous teeth, extreme displacement of teeth or transposition of teeth may be seen. So here in the clinical picture you can just see that fibrous overgrowth of jaw is there and the teeth are like displaced or show presence of spacing in oral cavity. So when you see normally this fibrous dysplasia, monostotic fibrous dysplasia, it affects the long bones like the tibia, femur. So when you see a radiologic picture of these lesions, a characteristic rind appearance is seen, rind sign is seen. What happens is there is absence of peripheral osteophytic reaction despite the presence of osteoblast, and the lesion is completely radiolucent. The long bone, it shows radiolucency in the diaphysis and metaphysis, and the cortex, it doesn't show any peripheral osteophytic bone reaction. So that gives the appearance of a rind sign seen in femur and long bones. So when coming to the oral cavity, when you see a radiographic picture, you can see that fibrous dysplasia shows three patterns radiographically. One is the presence of a small unilocular lesion or a multilocular lesion. Both show presence of trabeculae, disordered arrangement of trabeculae, with well circumscribed border is seen initially. So as in later stages you can see the trabeculation is more increased and the lesion appears radio opaque. This radio-opaque lesion then is mottled in appearance. It shows mottled. So initially you can see a unilocular lesion with a well circumscribed border. So then you can see the trabeculae are more coarse, they increase in number, they are more disorderly arranged, and they give a mottled appearance. So opaqueness starts. So as the lesion becomes more and more radio opaque, that gives an appearance of a ground glass appearance or a PUD orange appearance. So that is characteristic of the fibrous dysplasia, ground glass appearance. Because the whole of lesion is replaced, the bone tissue is replaced by the fibrous tissue. So when you see the clinical features, now the histological features, so irregular presence of proliferating fibroblast is the characteristic feature here. Whole of stroma, all of the connective tissue shows it becomes fibrillar in nature with presence of fibroblasts. The collagen fibers may be seen. The osteoblasts are reduced in number. And immature bone or irregular trabeculae of bone is seen. These irregular trabeculae of bone are give the appearance of a C-shaped appearance, also known as Chinese letter pattern appearance. So these trabeculae are present, immature, very few, disorderly arranged. So that gives the appearance of the C-shaped or the Chinese character shaped. So this is a histologic picture of fibrous dysplasia. On the extreme right side, you can see that is the normally deposition of bone. It goes on that way. So when you see the left side, you can see the trabeculae, the dark pinkish color, they are deposited here and there. So the whole of the bone is disorganized. So now we will study the polyostotic fibrous dysplasia. Polyostotic fibrous dysplasia also affects the whole of the axial skeleton, the long bones and the jaws. It is age of incidence is seen in about all younger individuals only, about first or second decade of life or more earlier than that. So it affects both males and females equally. Primarily the bones of skull and the long bones of skeleton, they show more commonly the polyostotic fibrous dysplasia. We have seen that polyostotic fibrous dysplasia is of two types. There is the Jaffe-Lichtenstein type or the McCune-Albright syndrome. So whatever be the type, these presence of fibrous dysplasia or expansile lesions, they are associated with the calf-A-lot pigmentation. That is the cutaneous pigmentation. This cutaneous pigmentation are nothing but macules. They may be present at the birth. They may be seen at the birth and they may be seen on back or lumbar bones, sacral bones or on legs. So this clinical picture, that it clearly shows why the term Leontiasis ossea has been attributed to fibrous dysplasia. So you can see the maxilla is affected by the lesion. So the nose shows the fibroosseous lesion here. So the oral cavity picture, it shows presence of teeth with excessive spacing. That is, there is displacement of teeth here. So, and when coming to this polyostotic fibrous dysplasia, McCune-Albright syndrome. McCune-Albright syndrome, as we have already discussed, it's associated with presence of fibrous dysplasia with the pigmentation. You can see the picture, the clinical picture of the child showing the pigmentation on the shoulder. That is nothing but the this brown pigmentation, macular pigmentation. That is the calf-A-lot spots. And such individuals show presence of variety of endocrinopathy syndromes like hyperthyroidism, acromegaly. So whenever the association of these three conditions occur together, then it has been called as the McCune-Albright syndrome. So here in the radiologic picture, we can see the CT image. If you take one image over the left side, so when you compare the right and left sides of the skull, you can see the left side is the normal appearance of the skull. So and when you see the circle pointed region, whatever is there, It shows deposition of bone or immature bone, which is giving the appearance of ground glass appearance. So that is the characteristic of this fibrous dysplasia. It's involving the maxilla actually. So when you see the microscopic picture of the fibroosseous lesion, essentially the stroma is fibrillar in nature, so the presence of spindle-shaped fibroblasts are predominant. So when the fibroosseous lesion involves the maxilla, it tends to spread into the maxillary sinus, orbital floor, or the zygomatic process. So because of the expansile nature, all the lesion extends into all the surrounding areas and extreme facial deformity is produced. So as we have already seen the microscopic picture, it's essentially a fibrous lesion, right? So there are presence of spindle-shaped fibroblast, and whatever trabeculae are formed, they are like irregular in nature. They show characteristic C-shaped appearance, and the trabeculae are essentially made of woven bone. So, and we have already seen the association of fibrous dysplasia with few of other syndromes. And sometimes the fibrous dysplasia, there is the interesting association between fibrous dysplasia and the myxoma that has been called as the Mazza-Brout syndrome. So, the treatment for fibrous dysplasia, it involves basically correction of the defect. If in case of Leontiasis osseous, such a marked facial deformity is there, so you have to correct surgical correction of the lesion is carried out for restoration. And cherubism is also associated with this condition, that is the fibrous dysplasia. It has also been, many authors have said that it is a variant of fibrous dysplasia, cherubism. And laboratory findings of fibrous dysplasia show normal serum calcium and phosphorus level. Only the serum alkaline phosphatase level is elevated. So here this clinical histologic picture shows the deposition of osteoid, that is a trabecula, whatever the dark pinkish color you can see, those are the trabecula. They are arranged in like irregular pattern and show variety of shapes. So that has been called as the Chinese pattern shape or the C-shaped trabeculae. So we have seen the major fibroosseous neoplasm, that is the fibrous dysplasia. Now we are going to the other fibroosseous lesions. Okay, they are nothing but the cemento-osseous dysplasia and the ossifying fibromas. So what is cemento-osseous dysplasia? Cemento-osseous dysplasias are basically fibroosseous neoplasms which are occurring in the tooth-bearing areas. So they show deposition of cementum-like material within the bone. So there are three types of cemento-osseous dysplasia. There is the periapical, focal cemento-osseous dysplasia, and florid cemento-osseous dysplasia. So we have to differentiate cemento-osseous dysplasia from fibrous dysplasia and ossifying fibroma, because histologically fibrous dysplasia, ossifying fibroma, and cemento-osseous dysplasia all are fibroosseous neoplasms, right? So all show presence of spindle-shaped fibroblasts and deposition of osteoid-like material. So you have to correlate the radiological clinical pictures along with the histologic pictures while giving diagnosis in case of few fibroosseous neoplasms. So based on their clinical and radiographic appearance only, the cemento-osseous dysplasias are divided into three types. So what is periapical cemento-osseous dysplasia? Periapical cemento-osseous dysplasia is a neoplasm, is the lesion which is seen in the periapical regions of the teeth. Whatever the associated teeth are there, all remain vital here. So you have to differentiate periapical cemento-osseous dysplasia from periapical cyst based on the finding that whenever there is periapical cyst or apical periodontal cyst, the associated tooth will be non-vital. But here in case of periapical cemento-osseous dysplasia, the tooth will be vital because it is more of a reactive action of bone in forming the lesion. So it's also known by other names like cemental dysplasia or cementoma. There is deposition of cementum, nothing but deposition of cementum. So, periapical cementoosseous dysplasia, it has a marked predilection for occurrence in females. It's seen in middle-aged individuals, and predominantly it is seen in black people. About 50 to 60% of cases are seen in blacks when compared to whites. So, periapical cementoosseous dysplasia, it has a more predilection for occurring in the mandibular anterior region. There is a mandibular incisor teeth. The periapical regions show a well circumscribed radiolucency. So radiologically what happens is, initially when the lesion just begins to appear, you see a unilocular circumscribed radiolucency. As the disease progresses, it becomes mixed radio-opaque radiolucent. So yeah, almost always these lesions are discovered incidentally on radiographic examination, because the associated teeth are vital, right? So there are no clinical symptoms. So the teeth remain asymptomatic, patient will be asymptomatic, and the lesions are like well circumscribed, very small in diameter, confined to the periapical regions. So radiographic picture is unique because earlier in the early stages of the disease it is radiolucent completely. In the later stages, as the disease progresses, there is deposition of cementum like material, then it becomes a mixed radio-opaque radiolucence, and in the later stages it will be completely radio-opaque lesion surrounded by a thin radiolucent rim. So radio-opaque in the center, surrounded by a radiolucent rim. The astonishing feature is that the periodontal ligament remains intact because there is no carious process in the tooth, or there is no periapical infection in the tooth. So the periodontal ligament remains vital here. So that's the periapical cemental dysplasia. It is seen in the anterior mandibular region. Now the focal cementoosseous dysplasia. It is a form of cementoosseous dysplasia which is more commonly seen in the posterior mandibular region, most commonly in the angle of mandible or associated with the molar region. Only the site is different. All features are like similar to the cementoosseous dysplasia only. So focal cementoosseous dysplasia, it is a benign lesion, and when compared to the periapical dysplasia, focal has a tendency for occurring more commonly in the white people. So about 70 to 80% cases are seen in white people, and it is seen in about middle-aged or older-aged individuals around 4th to 5th decade, and they also have a marked predilection for occurrence in females. Initially, the lesions are asymptomatic. Sometimes when there is like the long span has occurred, or there is some amount of bone expansion, the lesion may be symptomatic. Radiographic features are the same for all the cementoosseous dysplasia. That is, initially it is a radiolucent lesion, then it becomes a mixed radio-opaque radiolucent, and finally it will be a radio-opaque with a thin radiolucent rim. Here in focal osseous dysplasia, the borders will be irregular. That is, you cannot see a well circumscribed lesion in case of a focal osseous dysplasia. Now coming to the florid cementoosseous dysplasia, it is a disease which is affecting the greater amount of jaw bones. That is, both the maxilla and the mandible will be affected. Periapical and focal, they are like constricted to few regions only, in the anterior mandible region, posterior mandible region, and surrounding the apex of teeth. But florid is a form which is widespread or distributed. It may occur in any region of the maxilla or any site of the mandible. It also has a marked predilection for occurrence in females, and more commonly it is seen in cases of black races. And it is affecting middle-aged individuals or younger individuals also. Around 2nd decade the disease process starts, and since it is asymptomatic, it is discovered on routine radiographic examination only, and it will take a longer time. The disease would have been present for a longer time before you detect it. Sometimes a dull aching pain may be present, and because florid forms involve the jaw bones, widespread expansion of the lesion is seen, the bone expansion is seen. Sometimes what happens is the avascular bone can be exposed in the oral cavity because of the amount of lesion. Clinically, swelling may be seen, swelling of the affected jawbone may be seen clinically. Similar to that seen in cases of fibrous dysplasia, same amount of swelling will be seen, but like necrosis of the bone occurs because the bone is exposed in the oral cavity. It becomes avascular, it is deprived of the blood supply, then it becomes necrosed. So radiographic feature of all the cementosus dysplasia are the same, that is initially radiolucent, then it becomes mixed lesion, then finally it is a radiopaque with a thin radiolucent rim. So when seeing the cementosus dysplasia, periapical, focal and florid form, the florid forms are like more destructive to the bone and teeth. When you see microscopic picture of cementosus dysplasia, all the three forms, they show the similar histopathologic picture, that is presence of spindle-shaped fibroblasts in the stroma along with collagen fibers and numerous blood vessels. So within the connective tissue, since the lesion is like from radiolucent, it is becoming a mixed lesion, that is radiopaque lesion. So there is being deposition of osteoid or cementum like particles in the bone. So with increasing deposition of bone, the lesion becomes radiopaque. Treatment for cementoosseous dysplasias is nothing but excision without recurrence. These lesions never recur, and the excision should be carried out only if it is giving you harm, like if you are feeling pain or if sufficient bone expansion is there that it's giving you cosmetic problem, only then it has to be excised or surgical excision should be done. Otherwise these lesions remain asymptomatic like that only. So the other commonest fibroosseous neoplasms are nothing but the ossifying fibroma. Ossifying fibroma, they are the true benign neoplasms, true benign fibroosseous neoplasms seen in oral cavity. They are also known as cementifying fibroma or cemento-ossifying fibroma. The names itself show that there is deposition of cementum-like material in a fibrous lesion. So it is like a true neoplasm. So the clinical features have to be, you have to differentiate this lesion clinically from fibrous dysplasia because they have similar clinical features. So when the clinical features appear to be similar, you have to move on to compare them with the radiological features. So small lesions are asymptomatic. When the lesions are large, they may cause considerable swelling of the oral cavity, bulge in the oral cavity, and then they may cause dull aching pain of the oral cavity. Ossifying fibrous lesions show marked predilection for occurrence in females, and they are most commonly seen in middle-aged individuals. The site where it is affected, more commonly affected, is the mandible, that is the premolar molar area. So sometimes when the lesion is sufficiently large that both the cortical plates have expanded, then you can see pain, and if the inferior alveolar nerve is involved, then paresthesia of the nerve or lip may be seen. So these are the clinical features. They are almost like similar to those of fibrous dysplasia, that is clinically in the oral cavity. If suppose it is involving the mandible, there is swelling of that area. So clinically you cannot make out. You have to go for the radiological feature to differentiate it from fibrous dysplasia. So in the radiograph, it appears as a well-defined or well-circumscribed unilocular lesion initially. Then the lesion becomes mixed radiopaque radiolucent with the deposition of cementum-like material. So when the lesion becomes sufficiently large, then it causes root resorption of the adjacent teeth, and it causes displacement of the teeth, or it causes the roots of the teeth to diverge in the area where it is present. Occasionally they may cause mobility of teeth also. So microscopically, ossifying fibroma shows presence of spindle-shaped fibroblasts, or it is composed of fibrous tissue along with the deposition of calcified material or cementum-like material, so which gives the radiopaque picture radiographically. So irregular trabeculae of bone or osteoid are seen deposited, which appear as basophilic in the histologic picture. So even the histologic picture is appearing to be similar of that of fibrous dysplasia, but radiologically you can just make out as the lesions are unilocular lesions. Ossifying fibroma, these lesions are unilocular lesions when compared to fibrous dysplasia. Right? Fibrous dysplasia shows histopathologically Chinese letter pattern appearance. Then radiographically you can see ground glass appearance. So here the lesion is more commonly radio opaque in nature. So that way you can differentiate both the lesions. So the other uncommon fibroosseous lesion is the juvenile ossifying fibroma. Initially authors reported that juvenile ossifying fibroma, it appears in two forms, like the trabecular variety, which shows deposition of trabeculae, and the zymomatite variety. Now these forms have been just moved away, and it has put that the juvenile ossifying fibroma, there are no two types, it's just the juvenile ossifying fibroma and the juvenile active ossifying fibroma. The name zymomatite is not being used currently. So the clinical features, juvenile, as the name indicates, it occurs in the younger individuals or children, more commonly children and middle-aged younger individuals. So patients will be younger than 15 years of age. Both males and females are affected equally, and most commonly the site of involvement is characteristic for this juvenile ossifying fibroma, as it involves the orbital and the frontal bones and the bones of maxilla actually. Whereas the other ossifying fibrous lesions or the ossifying fibroma, it has a predilection for mandible. So the juvenile variant, it is more commonly seen in the orbital, frontal bones and the maxilla bones. So that's the site is different. So initially the lesions are of slow growing lesions. This way progressive growth and pain and paresthesia will be noted because of involvement of the orbital and frontal bones. The paranasal sinuses may be underdeveloped, and features of sinusitis may be seen. And both the orbital and frontal bones show swelling, so there will be facial asymmetry, and a bony expansion of the region occurs. And exophthalmos, that is the eye appears to be protruded, the bulging of eye is seen, proptosis and nasal obstruction are the features encountered. So here the CT image shows you the nature or the fibro-osseous lesion in the orbital bone. The arrow points to the region of fibro-osseous lesion showing the picture. So radiographically nothing but they show presence of central radiolucencies with a peripheral radiopacity. That is, the lesion is essentially of radiolucent nature, but it shows a peripheral just radio-opaque rim. So microscopically you can see that there are two variants of juvenile ossifying fibroma, right? Trabecular juvenile ossifying fibroma and zymomatite juvenile ossifying fibroma. Both have a different histologic picture. The trabecular variety, it shows deposition of the trabeculae, irregular trabeculae-like structure. So the lesion is, the connective tissue is essentially the fibrocellular one, which shows deposition of hemorrhage cells, and whatever the cells are present, they show clumping or crowding of the nucleus. There is nothing but the nuclear crowding, and multinucleated gain cells are seen. So the trabecular variety shows increased deposition of osteoid form, or the irregular trabeculae are deposited, which are lined by osteoblasts, nothing but cells showing the deposition of bone. Here the zymomatite variety, it shows presence of ossicles, cementoid ossicles. These ossicles are radio-opaque in nature radiographically. So these deposition of ossicles, they in the histological sectioning, they appear as basophilic centers or pink structures, which are lined by osteoid rims. That is the radio-opaque in nature. So they are basophilic center with eosinophilic osteoid rims. That is the when you see the microscopic picture there, the pink color one, that shows the ossicle, which is lined peripherally by the osteoblast or the osteoid rim. That is, the osteoblasts are responsible for depositing the osteoid material, right? So the ossicles are just lined by the osteoblast cells. So coming to the treatment for juvenile ossifying fibroma, smaller lesions which are not producing any form of facial asymmetry or any other pain are to be just curated, whereas larger lesions which are involving the greater amount of orbital bone or the frontal bone and producing exophthalmos, nasal obstruction, they have to go for surgical resection. A wide area of resection has to be done, and the defect has to be corrected. Since it's occurring in the younger age individuals, like below the 15 years of age, so surgery is like necessary to restore them back to their previous good health. So recurrence rate of about 30 to 58% has been reported. So that's why juvenile active osseous fibroma, though being benign, it's considered of great significance because of its recurrence rate. So we have seen all the fibroosseous neoplasms or the fibroosseous lesions. That is nothing but the fibrous dysplasia, the cementoosseous dysplasia, and the neoplasms, that is the ossifying fibroma. So these are the most important or the common ones. So apart from the fibroosseous lesion, now in the diseases of bone or the pathology of bone, we have seen the developmental disorders or the developmental disturbances and the diseases of bone of questionable etiology, that is the Paget's disease and the fibroosseous lesions. These are the most important ones, and there are lesser known diseases also, like the one which are caused by the endocrinal disturbances. There is a case of hyperparathyroidism. Then the reactive lesions of bone, nothing but the central gain cell granuloma or the aneurysmal bone cyst or traumatic bone cyst, which we have which we'll study in the other chapters, like the physical injuries, because traumatic bone cyst is mostly caused by the trauma. Then we'll see now the skeletal dysplasias or the congenital bone disorders which are seen by birth or at the time of birth. So congenital bone disorders or the skeletal dysplasias, deformations or malformations in the skeleton itself. So there are many variety of syndromes. We are going to study the most important ones. The first is the Marfan syndrome. Marfan syndrome is also known as arachnodactyly, nothing but presence of long limbs. So the overall appearance of the person, it appears to be lengthy. The hands and legs especially appears to be lengthy, and the face appears to be long and narrow. When compared to children of that age, the patients have relatively longer limbs and long face. So Marfan syndrome, actually the genetic defect in connective tissue. It is a connective tissue disorder. So gene mutations give rise to this disease. It is transmitted as a autosomal dominant inheritance. It's more commonly seen in children. It's detected in children, actually present at the time of birth, but usually noticed at the time of like 10 to 15 years of age. Marfan syndrome incidence is 1 in 5,000 live births. So the clinical features of Marfan syndrome are diagnostic. It affects the skeletal system, right? So dolichostenomelia is nothing but presence of relatively longer limbs when compared to the trunk. So the body appears to be small, but the limbs, the hands, the fingers all appears to be relatively longer. And there is hyperextensibility of the joints. That is, normally you can't just rotate your thumb to 180 degrees. But children with this syndrome, Marfan syndrome, has such hyperextensibility that they can just rotate their thumb anyway. And the presence of the skeletal defect, it is also associated with congenital heart defects like aortic dilatation, auricular septal defect, ventricular septal defect, mitral valve prolapse. So presence of skeletal disturbances or disturbances in the bone along with congenital heart defects is the characteristic feature of Marfan syndrome. So the presence of all these features which are affecting the skeletal system do not pose any harm in normal living or the normal well-being of the individual, but the congenital heart defects have to be taken care of. Adequate treatment has to be given as and when need arises. And when you see the oral cavity of the individual or the children with Marfan syndrome, you see that the presence of a high arch palate, and there is increase in the height skull height. The patient has a relatively longer face than usual, and presence of bifid uvula and multiple odontogenic cysts of the maxilla and mandible. So when you see these are just the clinical features. When you see the radiographical features also, you see that the height is increased. There is the skull height is increased. The skull appears to be long, and there is enlarged frontal sinus and presence of a high arch palate, and the limbs appear to be relatively longer, and even the fingers appear to be longer. There is both the carpal bones, metacarpal bones, all are relatively longer. So the treatment for Marfan syndrome is just the congenital heart defects, whatever are present, that should be taken care of. Craniofacial dysostosis. Craniofacial dysostosis is nothing but disturbances or the early closure of the sutures. So that denotes the craniofacial dysostosis. There are variety of syndromes coming under craniofacial dysostosis. We will study Clausen syndrome and Apert syndrome. Both the Clausen syndrome and the Apert syndrome, they are craniofacial dysostosis syndrome. But the Clausen syndrome, it occurs without syndactyly. Syndactyly is nothing but the fusion of digits, fusion of the limbs, fusion of the fingers of hand or limbs, legs. But Apert syndrome, it occurs with syndactyly. There is fusion of the digits in Apert syndrome. So first we will study the Clausen syndrome. Clausen syndrome, earlier it was known as the craniofacial dysostosis. Now it has been referred to as Clausen syndrome or disease. The defect here, it is the mutation in the fibroblast growth factor. So whatever the fibrillin gene, it codes for the normal receptors, it is being mutated. So then this defect arises. The basic defect here is the early synostosis of sutures. That is when the sutures, whatever the coronal suture, sagittal suture, lambdoid suture, each have a specific time to close. So by the time they closes, the skull or the brain should have grown to sufficient size. So here in the Clausen's disease, the sutures close early. So the brain or the skull, they don't grow appropriately. So you see brachycephalic skull, brachycephalic, there is a short and wide skull when there is early closure of coronal sutures. So the early closure of coronal suture, what happens is the skull doesn't grow in anteroposterior direction. So the skull grows just in the transverse direction. That is, the skull appears to be wide transversely and narrow anteriorly. So prominent of the frontal bone, that is the frontal bossing, is seen here. And the skull appears to be dolichocephalic when the sagittal sutures close early. So whenever there is earlier closure of sutures, what happens is sufficient bone growth or the sutures close normally the sutures close only when the skull or the brain has grown to sufficient size. But because of early closure of sutures, there is increased intracranial pressure. This leads to hydrocephalus and a variety of brain compression syndromes, and neurologic disturbances, CNS disturbances are seen. So, and the characteristic feature of Clausen syndrome is the appearance of a frog face. So, the facial features, whatever are encountered in this syndrome, they give the appearance of a frog face. Like if you see the clinical picture there, so the eyes appear to be wide and widely separated. The distance between the two eyes is increased. That is nothing but the hypertelorism. Then the face appears to be wide. Transverse growth is more, right? So the face appears to be wide and the ears appear to be low set ears. And the maxilla is hypoplased. There is hypoplasia of maxilla. The mandibular growth is not affected, but it appears to be prognathic because of the hypoplastic maxilla. There is a relative prognathism, that's called. And optic nerve atrophy is seen because of the early involvement of the sutures. And the characteristic dermatologic manifestation for the Clausen syndrome is the presence of a dark color skin. The acanthosis nigrans is the manifestation of Clausen syndrome. So when you see radiographically also, you see that the sutures are obliterated. The fontanelles, anterior fontanelle or posterior fontanelle, whatever are seen, they are still persistent and they are pulsating in origin, even in cases of middle children when they have crossed their middle aged also. The fontanelles will be pulsating. And these, along with that, the spine is also affected. Presence of bifid spine sometimes is noted, and the maxilla appears to be retruded because of its hypoplastic nature. So all these features denote the Clausen syndrome. So Clausen syndrome is a craniofacial dysostosis syndrome. Another syndrome which is of shows early closure of sutures is the Apert syndrome, but it occurs along with other features like syndactyly that we'll be studying later. So other commonest skeletal dysplasia is the mandibulofacial dysostosis. Mandibulofacial dysostosis, it's also known as a Treacher-Collins Francescity syndrome. It is more commonly, the defect here is the retardation of growth of the maxillary mesoderm in the second stage of fetal life. The maxillary mesoderm, the growth is retarded, that leads to development of this syndrome. It is transmitted as autosomal dominant inheritance. It is more commonly encountered. It is the commonest, like, because it is seen in 1 in 25,000 to 1 in 50,000 live births. So the affected individual, it shows characteristic bird face deformity. So the mandibulofacial dysostosis, the facial features of this syndrome, they give a bird-like or a fish-like face appearance because of the following features. First is the presence of low set ears. There is as you see during embryologic development, the ears will be low set initially and then they get back to its original place as the as the fetus grows. But here the ears will be low set and the auditory ossicles, that is the bones responsible for formation of ear, will be absent. So complete external ear will be absent, or if present it will be malformed. The folds of external ear will be absent. That is concerning the ears. When compared to the face, there will be hypoplasia of the facial bones. That is, the malar bones will be underdeveloped or very poorly developed, and there won't be any fusion between the malar bones and the zygomatic bones. So even the face appears to be like underdeveloped or retruded in origin. Then when coming to the eyes, there will be absence of eyelashes, the deficiency or complete absence of eyelashes, and characteristic anti-mongoloid features will be present. When we see the Down syndrome has characteristic mongoloid features. So here in Treacher-Collins you can see anti-mongoloid features. That is, the palpable fissures are like slanting of palpable fissures. The palpable fissures will be drooping towards the corners of the eye, and there will be coloboma of the lower eyelid. So, and when seeing to the oral cavity, when coming to the oral cavity, you can see the presence of cleft palate. This is because mandibular hypoplasia occurs here. So because of that, the tongue remains high in the oral cavity and that leads to presence of a cleft palate, and the palate will be high arc palate is seen, and macrostomia is seen. So all these features give the characteristic fish face or a bird-like face. Even the nose appears to be depressed here. So radiographically, the characteristic feature is will be the malar bones will be grossly underdeveloped, and they will not fuse with the zygomatic arch bones. And presence of cleft palate, the auditory ossicles will be completely absent. So that's about the Treacher-Collins syndrome. It's like the child leave a normal birth, but cosmetic surgery has to be corrected because you have cleft palate, and because of the presence of cleft palate, you can see variety of dental and dentoskeletal malocclusions all have to be corrected. Basically, cosmetic surgery has to be done. The other common skeletal dysplasia or the syndrome is the Pierre-Robin malformation. Pierre-Robin malformation is also known as the Pierre-Robin syndrome or Pierre-Robin sequence. It occurs as a isolated defect only, or it can be seen in presence of other syndromes or other manifestations like that. So we'll see the isolated defect here. So Pierre-Robin syndrome, actually it's a group of occurrence of Micrognathia, cleft palate and glossoptosis. Together, three of them make the Pierre-Robin sequence or the Pierre-Robin syndrome. So Micrognathia or retrognathia, that is the lower, most commonly the mandible will be retruded or it will be smaller in size. Then the presence of cleft palate. Glossoptosis is nothing but the tongue will not be a large size, but because of the retruded mandible, the micrognathia of mandible, the tongue appears to be larger in size and it obstructs the oral cavity, and there will be difficulty in respiration and eating and speaking difficulties. That's it. So there have been a lot of theories proposed for explaining this Pierre-Robin sequence. The most commonest or the widely accepted one is the mechanical theory, which states that the retrognathia, whatever we are seeing, it's because of the mandibular hypoplasia which is occurring during embryonic development at about 7th to 11th week of gestation. So because of the mandibular hypoplasia, the tongue which remains high in the oral cavity, failure of fusion occurs, failure of fusion of palatal process occurs, and the cleft remains. The cleft will be like V-shaped cleft. And the other commonest theory is the delay in neurological maturation of the cells that gives rise to micrognathia or the syndrome. So the clinical features of Pierre-Robin are nothing but the occurrence of micrognathia. So the middle third, lower third of face appears to be retruded, and it is more commonly seen in cases of equally distributed, that is both males and females are equally distributed, and the incidence of occurrence of Pierre-Robin malformation is like 1 in 8,500. And presence of micrognathia, cleft palate, both are V-shaped or a U-shaped cleft palate may be seen. Along with cleft palate, it gives rise to difficulties or displacement of teeth, and other associated dental defects are seen, spacing or malocclusions, whatever. And along with this, the ears will be low set here. Almost all the congenital disorders, whatever we are seeing, because they are occurring during the embryonic development, the ears will be like low set, and associated hearing defects like hearing loss, otitis media may be seen. And Pierre-Robin, sometimes it's associated with skeletal manifestations like presence of syndactyly. There is a fusion of digits is also seen here, and CNS defects like developmental delay in speaking or during growth of child. So like little bit difficulties are encountered in growth, like language delay is seen. He may understand the language but he may not speak the language, the child. Then epileptic seizures are seen more commonly. So that's with Pierre-Robin malformation. It is maximum of the times it is seen associated with other syndromes, like isolated defect is relatively uncommon. So the Apert syndrome is another common syndrome encountered. It is also a craniofacial dysostosis, that is the early closure of sutures occur here, along with the presence of skeletal manifestations like syndactyly. So it's also, Apert syndrome, it's also known by other names as acrocephalosyndactyly. The name itself gives that acro means long, cephalo head, and presence of fusion, that is syndactyly, fusion of digits. So it is transmitted as autosomal dominant inheritance, and the etiology of occurrence is there is some mutation occurring in the fibroblast growth factor. So there is defect in the fibrillin protein that gives rise to all the manifestations, skeletal manifestations. So early closure of sutures occur, either the coronal lambdoid suture or any suture which is seen. So based on the closure of sutures, corresponding defects may be seen, like dolichocephaly. It is seen in case of early closure of brachycephaly. It is seen in case of early closure of coronal sutures. Dolichocephaly, it is seen in case of early closure of sagittal sutures. So brachycephalic appearance, the skull will be short and it will be wide transversely. Anteroposterior diameter will be small. So that acrocephaly, the flat occiput and prominent frontal bossing is seen. Anteroposterior diameter is limited, right? So the frontal bossing or the prominent frontal bone is seen, and the skull is wide. And when you see the nose of the individual with Apert syndrome, you see that the nose is markedly depressed or wide, and it gives the appearance of a parrot beak appearance. So parrot beak appearance is characteristic of Apert syndrome. So the external nares also sometimes they will be wide here. When coming to eyes, the distance between the two eyes is increased, as in case of other Clausen's disease, Clausen's syndrome. There also we can see hypertelorism, and the eyes appears to be protruding out. That is the proptosis or exophthalmos like condition is seen in case of Apert syndrome. So the skeletal manifestation is nothing but the syndactyly. So if you can see the clinical picture of the child here, you can see that the eyes are widely separated. So the nose, the external nares are a little bit wide, and there is depression of nose. There will be like a burrow like a thing, or the eyebrows are widely separated, and there will be groove like a thing at the forehead. So that gives appearance of a depressed nose. So that's about the parrot beak appearance. So the eyes are relatively lower set. When coming to the oral cavity, you can see that there is presence of a cleft palate, and maxilla appears to be hypoplastic. So associated with cleft palate, you can see all other defects like missing teeth, or displacement of teeth, or spacing of teeth. All dental defects can be seen. So the drooping angles of mouth, because of the maxillary hypoplasia and because of the low set ears, the angles of mouth, the corners of the mouth, they appear to be like a inverted smiley, like it appears to be downwards C-shaped like, and there is presence of bifidobula. So we have seen the skeletal manifestations, the appearance of nose, the appearance of eyes, and the appearance, the manifestations of which are seen in the oral cavity. Coming to the skeletal manifestations, the characteristic is the fusion of the third and fourth digits of the limbs, fingers or toes. So the third and fourth digits, they appear to be fused. It may be a bony fusion or a cutaneous fusion. That gives the appearance of a mittened hands and soft feet. Normally what happens is during embryologic development, cell death or apoptosis takes place, that gives rise to division of fingers. So if there is a defect in cell death or apoptosis does not occur, so that gives rise to this fusion of fingers. So that so you can see even in the clinical picture, the characteristic mittened hands appearance is seen. Sometimes all of the digits may be fused. So that's with the Apert syndrome. So now the other skeletal dysplasia is the Robinow syndrome. It was actually given by the name was given by Robino syndrome. Actually, the author Robino, he noticed some characteristic facial features in 8 months old infant. He reported them, and that have been described as the Robino syndrome. It's also known as a fetal face syndrome. There are two types of Robino syndrome, that is the autosomal dominant form and the recessive form. The recessive form appears to be more severe than the dominant form. So the mode of transmission is both recessive and the dominant one. So the characteristic features, whatever are seen, they are like skeletal manifestations. When coming to the skeleton, the child will be little bit of short stature, that is broad and short stature, that is the child appears to be dwarf. And when you see the limbs, the brachystenomegaly, that is the outer arms appear to be shorter. The outer arms appear to be shorter. And presence of very small hands with fusion of digits may be seen, and the feet will be relatively small. Ears will be low set because this is occurring during embryologic development, right? That's about the skeletal manifestations. When coming to the craniofacial manifestations, the distance between the two eyes is increased. There is hypertenotic eyes may be seen, and the nasal bridge is wide and broad, and the jaw size is reduced. That is, the micrognathic appearance is seen. When coming to the oral cavity, again presence of a cleft lip or palate is more common. When we see almost all of the congenital disorders, they are showing the presence of this cleft lip or palate. Cleft palate is more common actually. So presence of malaligned teeth, associated malocclusions with the presence of cleft palate. Bifid uvula is also seen, and gingival hyperplasia is encountered. So if you can see the radiographic picture there. So the radiographic picture of hand, it shows that the outer arm, forearm, it's relatively shorter when compared to the upper arm. It's not being clearly seen, but that is nothing but the brachystenomegaly, presence of a short forearm. And oral cavity, you can see the presence of a cleft palate. And the vertebral manifestations are more common. The presence of a butterfly-shaped vertebrae was reported, especially in ribs. So Robino syndrome, along with the skeletal and other craniofacial and oral manifestations, the other characteristic feature is the vertebral manifestations, that is the presence of a butterfly-shaped vertebra. So the other commonest syndrome encountered is the Down syndrome, also known as trisomy 21 syndrome. It's more commonly seen in children born at delayed maternal age, that is around 35 or 40 years of age. It is very common. Incidence is about 1 in 800 to 1000 live births. So it's like more commonest syndrome among all the congenital disorders, bone disorders, or the skeletal dysplasia seen. So it has affected both the skeletal system, eyes, craniofacial manifestations are also there, and heart defects are seen. So association of these three is seen: skeletal defects and heart defects along with craniofacial manifestations. So when coming to the skeletal manifestations, the individual will be of a short stature, broad and short appearance is seen, broad hands, and the curved fifth finger. The fifth finger is curved, and when you see the palm of the child, we have so many lines or palmar creases, but the child affected with Down syndrome will have only a single palmar crease, that is one palmar crease. And the most characteristic feature of Down syndrome is the occurrence of mental retardation. The children with Down syndrome, they have an intelligence quotient of just 25 to 50, when the normal for a child, the IQ intelligence quotient should be about 100. So here it's about 25 to 50 only. That is also mild to moderate cases, they show that 25 to 50. So along with presence of all symptoms, the presence of mental retardation or delay in learning, speaking, or language delay, that is the characteristic feature of Down syndrome, which is like not seen in other syndromes. And the appearance of a skull, it gives a brachycephalic appearance. The eyes are, the distance between the eyes is increased, they are widely spaced, the hypertildric eyes are seen, flat occiput is there. And characteristic mental retardation. When you see the trunk of the child, he has a protuberant abdomen and slanting palpebral fissures are seen. Ears are relatively low set ears, and a broad and short nose is seen. And the tongue appears to be of larger in size, macroglossia, and because of the large size tongue, the saliva will be continuously drooling out of the corner of the mouth. This dripping of saliva is seen. And the maxilla is hypoplastic, and defects of teeth like enamel hypoplasia are seen. So associated with maxillary hypoplasia, relative prognathism of mandible may be seen. So the face have a concave appearance. So partial anodontia, there is absence of congenitally missing teeth, congenitally missing or delay in failure of eruption of teeth may be seen. So the characteristic feature of this Down syndrome is the presence of white spots in the areas. These are known as brush fields spot. So the hard defects seen in Down syndrome are the presence of atrioseptal defect, ventricular septal defect, or tetralogy of palate, or the mitral valve prolapses. All these are give a indication of a Down syndrome. Basically, the major correction or the treatment part is proper care of the child, because he is like mentally retarded with a very low intelligent quotient. So proper care or upbringing of the child should be taken. Down syndromic child are more commonly, they show problems in the periodontal problems, because continuous drooling of saliva is present. Dental caries is relatively uncommon, but the periodontal diseases are more common. So that have to be taken care of. Because the child is mentally retarded, he cannot take care or he cannot maintain his teeth. So that's the problem. So